Hi, everyone. This is Alessandra Dornti. I am recording my verbal case study for Nursing 6341. And today I'm presenting a case study on a 68-year-old Caucasian male with a history of COPD, hypertension, and obesity who came into the clinic for a acute COPD exacerbation. So he came into the clinic with a chief complaint of saying that I'm just not breathing like I usually would. I am short of breath. I've been coughing up more green sputum, and my inhalers aren't helping the way they usually do. So when we interviewed him further, he said that he had been short of breath for the past 3 days, that it had just been getting worse. He had been more tired, and he'd had a more productive cough than he usually did. He denied fever, chest pain, hemoptysis. He denied any leg swelling. He denied any GI, GU concerns. And he also denied any like neurological changes. He's alert and oriented. He said he hasn't been dizzy, lightheaded. He has not had any nasal drainage, not had any racing heart rate or bradycardia. No changes in bowel or urinary habits, no frequency, urgency burning, and no muscle aches or joint swelling. So, but he has been using his albuterol inhaler daily and his tiotropium once a day, and he says they're just not helping like they usually are. Medical history wise, he has COPD, gold stage 2, that was diagnosed 10 years ago. He has been hospitalized twice previously for COPD exacerbations, but none within the past year. He does smoke 1 pack a day, and he has nighttime oxygen available to him. He says that he sometimes uses it, most of the time, 2 liters at night. He also has a history of hypertension. He takes lisinopril 10 milligrams daily, and he says his blood pressure is usually controlled on that. He does check his blood pressure at home and keeps a log of it. He also has a history of obesity. For his review of systems, so positive for increased cough, dyspnea, green sputum, negative for fever, chills, chest pain, the nasal drainage, all the things. He has no history of surgeries. As far as family history, his father died of a heart attack at 72. His mother is still alive at 90 years old. She also smokes, has a history of COPD and hypertension, and he has no history of genetic lung conditions. Social history, he's retired. He was a postal worker. He lives at home with his spouse. He smokes 1 pack a day, no drug or alcohol use. He does not have much physical activity, and by his own admission, he has a fairly poor diet. He does eat a lot of processed foods, high sodium foods. He has Medicaid, and he also has private insurance. His medications and allergies, like I said, he does take that lisinopril 10 milligrams. He has tiotropium daily. He has albuterol PRN that he usually takes once a week when he's doing good, but lately it's been every day. He has no allergies, and he is good about getting his flu and COVID vaccines as well as his pneumonia vaccine, and he got all those last year. Okay, so moving on to his objective section. So vital signs were temperature 98.7, blood pressure 34/76, heart rate 94, respirations 22, SpO2 91 on room air, 95 with the 2 liters of oxygen that he has with him. He does have his condenser with him. And then his BMI is 32.7 today. When I was looking at him, he was mildly dyspneic. You could tell that he was short of breath, but he was still able to speak in complete sentences. He was able to, walk in and out of the room, walk in and out of the clinic okay. And he was not wearing oxygen when he came in, although his wife brought it with him. Starting our assessment. So ears, eyes, nose, throat. His throat was not red. He had no nasal drainage. His eyes were clear, non-injected. He does not wear glasses. He has great eyesight, he says. Looking in his ears were, his eardrums were pearly gray. They were non-bulging. His ear canals were not red. He said he does not feel ill today. Neurologically, he's alert, oriented, does not report any lightheadedness, dizziness, and no recent headaches. Respiratory wise, he does have some bilateral expiratory wheezing with prolonged expiration and a little bit of diminished lung sounds at the bases. His heart rate is regular and rhythmic with clear S1, S2, no murmurs. His extremities showed no edema. He has good cap refill in all four extremities. He has clear bowel sounds that are not hypo or hyperactive. And his skin is intact with good turgor. So for this patient, we did send him for a chest x-ray, which when we got the results back showed hyperinflation, signing of his COPD, but no infiltrates, no pleural effusions. On his labs, his WBC was elevated. It was 11.8. His CRP was elevated at 15.4. And his prior spirometry, his FVC was less than 0.7. And his FEV1 was at 55% of his predicted. So our assessment, this is a moderate exacerbation of his COPD. The ICD-10 code is J44.1. And this is evidenced by his increased sputum, his dyspnea, his abnormal vital signs, but this is not requiring hospitalization at this point. Our differential diagnoses are pneumonia, J18.9, which we ruled out by the absence of the fever, the absence of chest pain, and his clear chest x-ray. And then we also ruled out CHF exacerbation, I50.9, ruled out by the lack of edema, no JVD, and a stable cardiac exam, no history of heart failure in his past. So our plan at this point, we gave him prednisone, 40 milligrams PO daily for 7 days. We gave him doxycycline, 100 milligrams PO BID for 5 days due to the CRP, the white count, and the sputum, just to make sure that we were covered. We did make sure he has a nebulizer. He had a nebulizer at home, but he did not have solution for it. So we went ahead and prescribed him some albuterol and ipratropium for his nebulizer every 4 to 6 hours as needed. We suggested that he wear his 2 liters of oxygen at all times for now. We encouraged hydration and rest. We counseled him on smoking. We have always counseled him on smoking. We did offer nicotine patches, which he said he was not ready for at this time, but we encouraged him just to think about it, that it would reduce his COPD symptoms in the future and that it's never too late to quit. We reviewed his inhaler technique, make sure he was using them correctly, making sure he was getting the full benefit of those. And then we did offer to try to get a referral to pulmonary rehab once he's feeling better. As far as follow-up, we actually called this patient later on in the day just to make sure that he picked up his meds, that he was using his oxygen, and to make sure that the nebulizer was helping. I wanted to make sure that he didn't continue to deteriorate. Then we also called him the next day, making sure that he was feeling better. And then we encouraged him to follow up about 2 days afterwards. So 3 days after the initial visit, we encouraged him to come back in and come see us. So our clinical reasoning, this all aligns with the GOLD 2025 standards. Normally, you wouldn't treat a COPD exacerbation with antibiotics, but according to GOLD 2025, this does qualify for antibiotics because of his sputum and the volume of it. The systemic corticosteroids reduce the recovery time and prevent treatment failure. And smoking cessation is always the most modifiable risk factor for all COPD patients. And then this does address AACN Essentials Domain 4 for a scholarship of nursing practice by making sure that we are checking those gold standards, making sure that we are keeping up on the most current evidence-based practice that we possibly can to provide the best care for our patients. Thank you, and have a good day.